Yeah. Thank you so much, Dr. Akarin. I have to say that I don't have to supervise him that much. He just introduced me. Thank you so much for a nice introduction. As you can see that, I do everything except HIV. It sounds like. So you might wonder why I'm doing what I'm doing here. Probably trying to convince you that I do a little bit of uh, data analysis, and maybe some of the technique you might find it interesting. So this is the picture of the building that I'm in at Chulalongkorn Hospital. If you want to find me, you can go to 11th floor. It's a neuroscience center. And my expertise is actually trying to understand the mind from the perspective of biology, which is a field called cognitive science or cognitive neuroscience specifically. And this field turns out to be very multidisciplinary. Okay, it's involved a lot beyond medical. Okay, it's also about human behavior, also about how humans decide, how humans use language to communicate with one another, and even go to physics to understand the substrate, the matter of the brain, how it gives rise to something complex as a human mind. From HIV perspective, it's somewhat related. You can think about this as HIV can affect the brain and also how the behavior can, more or less making the control of the HIV easy or difficult. But to understand the brain is a very complex system. So people will try to understand the brain, try to understand what we call intelligence. And we're trying to understand intelligence. Some of them, in the era that computers become more advanced, they dare to think that maybe one day we'll be able to teach the computer to think like human. And that gives rise to the field that call artificial intelligence, okay? And artificial intelligence is actually the field that came from a lot of people from multiple disciplines. On this screen alone, you see Jeff Hinton on the right upper, you see Demis Hassabis on the left lower corner. Jeff Hinton is actually a psychologist, and Demis Hassabis is actually a neuroscientist. Both of them won Nobel Prize Award this year for chemistry and physics, respectively. Ilya is the one who do OpenAI. Maybe one day he'll win Nobel Prize too, who knows. So my agenda today is to maybe talk about these interesting tools a little bit, and maybe I will try to give you a use case from my perspective as a neurologist outside the use case of HIV, and then go back to HIV a little bit, because from what I'm trying to summarize, it seems like the HIV field in general hasn't been using AI as much compared to other fields. And I'll end with some challenges that maybe you'll find interesting. So with artificial intelligence, actually, on the first day I saw that some of you might already went to a workshop, but I'll give you a brief tour anyway. So there's some confusing terminology that people might find it very, confusing, like I said. But artificial intelligence is a very general term. It's like if you have any system that's trying to be smart, okay, whether it's a reminder as simple as that, or something that rule-based that you program it to do exactly what you want them to do, this is already called artificial intelligence. The subfield of artificial intelligence is what we call machine learning. And the keyword is learning, meaning that it should get smarter over time. If it gets more data, it will get smarter. So it will not work exactly the same every single time. It's not a rule-based kind of thing. It's not just a stupid reminder. But if you give them the data, it should be able to learn the pattern or learn to classify it, okay? And the subfield of the machine learning is the one that trying to imitate human brain, try to draw inspiration from neuroscience. This is a field called artificial neural network, okay? So I think the broadest one that would be useful is machine learning, right? Because you can have a lot of algorithm. It doesn't have to imitate the brain. But the main components of machine learning is data set, algorithm, and features, okay? And there's 4 types of machine learning these days. Used to be just 3, but now generative AI is a thing. So we have supervised learning, which means that you have to supervise the machine, tell them what's right or wrong. Unsupervised learning, which is let them learn the pattern of the data by itself. Number 3 is reinforcement learning, which is give them reward only when they get it right, but tell them nothing about the rules. Generative AI is learning to generate the data. instead of trying to summarize the data, learning how to regenerate the data. So you can imagine this as a picture, right? So supervised learning needs two things at least, the data and the ground truth. Some call labels. I mean, I think ground truth would be, in medical field, be familiar with gold standard. It's like diagnostic test need gold standard. That's exactly what it is. Then you can do classification or regression, which is telling them to regress the data just like linear regression, or classify just like logistic regression. The unsupervised learning, on the other hand, assume that the data, it's very complex, but the truth has lower dimension. So you should be able to look through the data and find the clusters inside the data. There's some limited cluster or subgroup of people beyond the number of measurements that you do. Say you do 3 measurements, you can think about this as 3-dimensional data. You do 10 measurements, that's 10-dimensional data, you cannot wrap the head around. You do 100 blood tests, you can have 100 dimensions. But actually the data could be as simple as you have healthy and unhealthy participants. So actually the data may lie in a lower dimension, but because you have big data, maybe there's a way to reduce the dimension, finding the pattern inside the data. That's unsupervised learning. Reinforcement learning, the famous one, I'll show you in a bit, but it composed of the agent and the environment, and the agent try to explore the environment. Every now and then, it will get given the reward, and they learn to do the same behavior over again. It's just Pavlov kind of thing that, the dog learned to associate condition with reward. And in generative AI, it's a special one that hit the ground, and people went crazy this day because it's able to generate the image or even generate a text that look or sounds like human talking. So I think supervised learning, it's very simple. You can think about it as extension from statistics that you know and loved. So you can have features, you have a lot of weights, you have output. In this case, it's just whether it's patients will, end up they die or not. So that's just a classification problem, right? The way that they do that slightly differently. Instead of just do model fitting, they split the data into a chunk that they call training set and a testing set. They fit the model to the training set and then trying to see if the model can generalize to the test set. They're trying to make the test set and training set as similar as possible, which is a subset of the data. They can do iterately, they do it over and over again to make sure that it can be generalized. But at the heart, it's not very different from statistics, just trying to make sure that it can be generalized. If you change the output just slightly, you can use exactly the same input, asking slightly different question. Instead of whether patients die or not, you can ask, how long did they stay in the hospital? This become regression problem. But the story is still the same. You need the extra column, which is the ground truth. You can think about it like this. You have cloud of data, you have parameter X and Y. If you're trying to draw a line that cut through the data, that's a regression problem. If instead you know that half of the patients or subset of the patient actually die in the hospital versus not, then what you're trying to do is, again, draw a line, but in this time, not trying to go through all the crown, but trying to separate the data into 2 halves. Okay, there's a name for that. It's called support vector machine. You don't need to even know the name, but there's many classification, right? Because you can imagine that, let's say, this X and Y, you can imagine maybe it's body weights and heights and something, but it turns out to be something that you cannot draw a line, just a single line to separate between the blue and the red population. You can actually do something else because there are many classifications that you can do. Actually, in medicine, we do it all the time. It's called guideline, right? We have this decision tree. If it's like this, you go to the left. It's like that, you go to the right and do it, so on and so on. This is exactly like you're trying to draw multiple lines to separate people into chunks because you know that there's some subgroup of people who would maybe end up having a different outcome. There's many of that. This is what we call decision tree, which is another classifier. Well, sometimes you can have more than one guideline. You not agree with your friend whether you're going to start with A or B or C. You can have multiple decision tree. and ironically, they call forest. So you can have multiple trees, you plant multiple decision trees, you ask them to do the classification, and you let them vote, and a majority vote will win. This is what we call random forest. So next time you read through the article, if you hear something like this, is not so scary. It's very simple. But sometimes the thing that I said earlier, you know exactly what the feature is, right? It's blood sugar, it's cytokine, it's everything that you know. But sometimes it's very difficult to turn that into a feature. Something like shed X-ray, right? Shed X-ray is just a bunch of numbers, actually. Say this is a high resolution picture. You can think about this as 1,000 by 800 pixel, which is 1,000 by 800 dimensions, because one pixel can be treated as one laboratory test, right? But then you can try to extract out all the features. It's just too many, right? Because the shed X-ray, the pixel that next to it usually carry the same information because it's redundant, just a picture. So the field is trying to build something that can extract out the feature that people will not be able to extract out. And this is what we call artificial neural network. Because they know from the visual cortex of human, it's composed of simple cells that look to the world through small window. It is somehow magically combine all of that information, pass it to the next layer of the brain, and you see the area that corresponds with face perception instead of a line perception. This is something that neurobiology has taught us since Huber and Wiesel, how many years back, who won the Nobel Prize. Jeff Hinton believed that if you want to build the intelligent system, why would you want to build it from the vacuum? You want to borrow it from brain. So he used this idea, borrowed the idea of receptive field and edge detection kind of thing, and built the layer of artificial neural network that pass on to one another. It turns out that you don't need to teach a machine what is meaningful in the image, but the machine, you just have to tell them this is pneumonia, this is not pneumonia, this is not pneumonia, this is pneumonia, just tell them that. It magically understands what pneumonia is in terms of the feature in the image. And people have been using this, trying to, like one of the earliest work in this, what we call convolutional neural network, is to use this instead of using a two-shed X-ray, they can use it with the image of the skin. This is discriminating, classifying between normal skin lesion and malignant skin lesion. And it did as well as dermatologist. Okay, that's supervised learning in a nutshell. Now let's move on to the unsupervised learning. Like I said, people, let's talk about outside medicine. People are trying to build a computer that will be able to read the zip code. And it's because the postman was just tired of this, right? They have to trying to read this human handwriting. They somehow think that maybe the number is just so simple. You just do the digital version of the number, then you just have 27 by 27, which is 729 dimensions. Maybe you can build a machine that can understand this number. They can train them to understand each number, but actually they think that, instead of it carries 700 something dimensions, if you have only the number that you know that only 10 number exists, 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, you can reduce the dimension. Instead of 70, 209, it's carry only maybe 2 dimensions is enough. It turns out to be the case. This is, using, I'm not going to go into detail, but this is what we call dimensionality reduction, asking whether you can plot in just 2 dimensions, discriminate between all of this number. It turns out that similar number will group to one another, similar number will group to one another. You see there's 10 islands in the data, even without any human label. Why it's cool? It's cool because sometimes you don't know the answer. And you hope to teach the machine the right answer, but you actually don't know the answer. At that point, you're hopeless, right? So you hope to see through the data and discover the pattern instead of teaching the pattern to the machine. And people are trying to use this to do personalized medicine. Say, we're talking about mental health. how many people know how many mental health diseases we have? I mean, you might want to open up DSM-5 or what, right? But then this is just a bunch of people get together and just decide how many mental health diseases we should have. You don't actually know the truth, right? So instead of doing that, you can get a bunch of data and try to see through the data. The reinforcement learning is actually doesn't get used in medicine as much. And the reason is because it's more like build an agent in the game that's smart, but then you have to build the environment that you know every bit of detail. In real life, you can't have the environment that say, you pretend to be a surgeon and maybe you're trying to cut something out and see a patient die. Then you have to have a pretty good simulation of that environment. It's very difficult. But people have done this before in the context of game, right? We have heard of AlphaGo. And basically, AlphaGo is like, there's a rule. And a computer just do random thing, and once in a while, if they win, they get a reward at the end. Only at the end. And they have to understand how to play this game. They play with a human, and then they go up the hierarchy to the point that they can win world champion. And now, once they win the world champion, the Google DeepMind, the people, Demis Hassabis would do this, designed to, instead of playing with human, they build another AI, play the game from the scratch, compete with one another, and then that algorithm can win the one that beat world champion, so like even better. And then they carry this information and say, oh, maybe we can do this in a different area. So they turn this AlphaGo into what? AlphaFold. And now in Alzheimer's disease community, have a machine that can predict how the protein misfold would happen. And this protein misfold would, give him Nobel Prize at the end. So it came from this reinforcement learning and AlphaGo. And now we have generative AI, which is very cool idea, actually. This idea is very simple. It's say, if you have a network of the neural net, you pass a high-dimensional data, you compress it to the lower dimension. Normally, previously, you just stop right there, right? You look at the lower dimension, just like MNIST that I show you, unsupervised learning. Or you can teach them, okay, this is A or B, that's supervised learning. But instead of just doing this, they connect it to a different layer and say, give me back what you just compressed. This is basically trying to tell them that this carries a lower dimension, compress it so that it will not lose any information because it's the state or the subspace that you can expand it back. So you give them number 3. You compress it down to lower dimension and ask them to split out number 3 again. So people can do this, like you have a noisy data, you compress it down, turns out it can learn what is noise and what is not noise, what is meaningful, and you can do denoise or compression by doing this variational autoencoder. It sounds like only like a fancy technique, but at the end, it gives you something very spooky, which is it can generate a pretty realistic picture. There's a version that there's 2 machines. One was trying to imitate the image, the other one trying to say whether it's a fake or real, and they compete with one another. That's called generative adversarial models. There's 2 AI systems competing with one another, super cool. One is generator, one is discriminator. And doing this way, you get a very realistic image, just like I did. This came from nothing. This is generate image. This is, from the learning perspective, it's also interesting because Richard Feynman once said, if you can't generate, you don't really understand. And I think like if you want to teach students to understand something, I think instead of asking whether they know whether this is cat or dog, you just ask your kid, can you draw a cat? If she can draw a cat, she can probably have a model of the cat. And now how many cats that she saw afterward, she'll be able to say, oh, that's a cat, because she has a concept of the cat instead of just an exemplar of the cat, if that makes sense. So this part, I will tell you about the use case that I just mentioned. I'm a neurologist. The first thing that I did was like, I also do some of the image drawing and in clinic, because if you have patients who might suffer from cognitive decline, you might ask them to draw something like this. I think it might make sense that, if you know that it's just a bunch of feature extractor, it doesn't have to be shared X-ray. So if you know that a different brain area would correspond with different pattern or clock drawing, you probably want to use convolutional network, apply it to cock drawing test, and see if we can identify disease versus control. So I collaborate with people within an aging clinic, do all the drawing tests that we know. We use MoCA tests, just 3 drawing tests, and the rest of the task. I wonder if we can just use drawing because it carries so much more than just 1 or 0, because you can just like, this is good or not good, right? But that's actually carry a lot of more information right there. So we do the digital version of this and then pass it to crazy convolutional neural net, ask them to classify whether it's patients who have MCI or not. I won't talk about it if it doesn't work, so it does work and get published in a respective journal. The other dimension that you might want to look at is that the way that people classify people, and I think it will resonate with all of you now. You have a bunch of questionnaires, right? And you want to say whether the patients have the disease or not. You just sum all the numbers, right? You sum all the numbers, have certain cut point, and say, oh, you fall below cut point, you actually have disease. Say you miss 5 points. Do you care whether that 5 points go to the first or the second or the third part of the questionnaire? You really don't care, right? Because you're about to treat that as the same if you only care about the threshold. So this is the work that I did with Akarin, and trying to see if we can uncover the hidden pattern of the MoCA test for those who miss 6 plus or minus 2 points. We specifically choose this narrow band to prove the point that it will not get clustered by the range of score. They have pretty much the same range of score, but you can still cluster them, right? We even split people into 2 halves and cluster them separately and overlay them. You can even see that they are different from one another because they're very stable. You can also think that once you have this tools, you can also try to measure it in a slightly different way, right? You can, instead of just look through the eyes, you can use something like you can digitalize motor movement or speech to be able to go to a different dimension. Here I want to spend a little bit of time talking about like how it can be done in HIV. And I think the useful framework is a framework that proposed by Dr. Fauci in 2019, that the objective of HIV from now on, at least in 2019, is to detect, to treat, to prevent, and to respond to emerging cluster. And there's a nice review that just came out and trying to see how the AI was done in different areas. So there's a step that they proposed that should do that I agree with. So you specify the objective, and then you specify the data set that you want to use, your sample size and descriptive analysis. Then you propose the algorithm that's going to get implemented, depends on what you want to do, like I give a brief tour earlier. Then you evaluate the model, and you're trying to share the data and code as much as possible because you want to make sure that it can get reproduced. Here's the table. I recommend you to check this Jiang in Lancet HIV in 2022 for more details. But I'm trying to summarize you in this little picture that this is not in the original paper, but I kind of like get everything together and see that there's actually 4 dimensions that you might care about: the data that they use, the algorithm that they use, the output of their model, and the objective. And you can see that you can have pretty much different data source going from demographic data, longitudinal data, biomarkers, and social network, even social network. For example, it can use social network data set, do graph analysis to identify opinion leader in a community so that they can do education to prevent or to make people use PrEP more, okay? So you can see there's a bunch of data set that you can use to the different specific algorithm and output. And this is the example of graph analysis. This is very useful analysis as well. I want to introduce to you briefly that you can use pretty much any relationship from one thing to the other, right? You can use it in social network. In neuroscience, we use brain as a model as well. So this is very interesting that you can look at the graph and you can identify different nodes, like different node would correspond to different person. And you can maybe see that this person connect to a bunch of people in particular. So that's what we call the hub. and the hub tend to connect to one another. That's called the rich man club. It's like a funny name, and it's a useful concept that you can use. There's some sentiment analysis to see if you do the campaign to HIV population and you want to see how people react to this. You probably can use NLP to try to curate a bunch of their comments and try to do sentiment analysis to see what they think about your campaign. So this is another one that's pretty fun, that they use unsupervised learning to classify people by their high-risk sexual behavior. Okay, and they can be able to classify people who have this risky behavior into 2-4 group, and they can plot this 4 group out and see the fraction of people who actually end up having bad outcome. And you see that if you break people into 4 group, they actually have separate fortune in the future, right? Some group would tend to have more, end up having bad outcome than the other. This is the group that they can cluster out. So in my opinion, if you want to do this kind of studies, what you have to have in mind is you know the activity that you want to have now, but don't forget that you need to build a team, the multidisciplinary team, that have both domain knowledge and skill set that needed, and also infrastructure in terms of data center and high computing power. Okay, now the last bit I want to talk about challenge, because it's not as smooth as everybody want it to be. You want it to have like a big machine that can predict everything, right? This is from Westworld, if you watch this movie. But there's many challenges. Number one is data. You might hope that data from one side would be able to use in Thailand or what's not, right? But the truth is, you want to have your own data set. You probably can leverage the big data set, but you still need to refine it to your local, right? Whether you came from whatever country, I recommend you to start to do the data collection. Try to harmonize with the big data to be able to leverage with the big data. Try to build a consortium so that we can all use the data and try to test our model and see if we can generalize to different community. There's a researcher to researcher communication challenge, because we don't know how to speak each other's tongue, right? So we don't know like what's a term that other people use. So I recommend you to do knowledge sharing, have something like seminar once in a while to talk about from people from different fields. Also, human and AI communication. I just mentioned that a bunch of good algorithms out there, but didn't get used in practice. Why? Because humans are the one who do the practice, who are responsible for the patient's outcome. If you only build the machine that hope to do whatever the human do, that's wrong. That's just wrong, because at the end of the day, we have to work together. We mean human and the computer, right? It's just like we have calculator. We should use it to our benefit. It's like, no, the calculator will, disrupt my calculation. I'm fine. I mean, who cares, right? So there's implementation challenge, which is, people have been doing the same thing over and over again. Even if it's super good, you have to find a way to trying to push it in that direction. You need the capacity building. You need a workshop to build the understanding and the adoption. We also need to make sure that once it gets implemented, it's still good for a little while, because once you implement something new, human behavior would change. You're not sure anymore whether it's still good. So building the AI model is a continuous process. You need what we call AI governance, which is a new concept this day. The last one is something that's very painful. It's like, who knows how to regulate all of this? So it's like a legal issue on top of everything. This example of trying to understand, make the AI explain why it did what it did. Something like, can you highlight what you think it went wrong so that I can understand why you said the patients have MCI, for example? There's a partnership that trying to compare between, if you use human alone, AI alone, and human versus AI, it turns out that some of the tasks, human and AI outperform AI alone and human alone. Okay, you have to think about how to make a decision with everything in a picture, in the same picture. Okay, I'm about to end now. You need to build a team, but this is an example of the team at Jula. We have hospital side who take care of data center. We have the faculty of medicine who take care of data science. We also have a partner outside who do slightly different thing and try to get together to make all of this happen. The last one is that the AI doesn't have a brain. And if you want to teach them to do something, you better want to understand why it did what it did or whether it do just like human. And this is a fun story that the AI community built an AI that can win the game, right? Like we talk about winning. There's some game that they don't win. So human did better, and it's a silly game. This game doesn't have any objectives. You just go one room to the other, just explore things. Right? The AI doesn't have this curiosity or trying to explore for no reward. Right? We human can build our internal reward. So there's some mismatch between AI and human. And trying to understand what's the mismatch would be able to make the human AI collaboration even more fruitful. I recommend you to read these two books if you're interested in this alignment problem, which is super important. And the last slide is that if you have a dragon in front of you, you have two choices. One is to fight the dragon. The second is to be dragon rider. Which one you want to be? Thank you.